as the second part, the main activity and damage indices of lupus. This is what we're going to try to review now in a somewhat subtle way. The activity and damage indices are the ones selected here, as I mentioned. A couple of special populations include the AIT in pregnant women or the ACLAM in the pediatric population, but I won't go into those. Then regarding the rest, just to touch on the distinction a bit, because at first I asked myself, activity, damage, what sets them apart? Well, really, as a sort of rough distinction, let's say, activity refers to any impact the disease has on a patient that can be reversible, and damage, accumulated damage, organ damage, is what is irreversible. As such, to begin with, if we had to stick with just one of all the indices I'm going to mention, it would be the SLEDAI-2K. This is the principal activity index based on its acronym. I read this one, but my group uses it too. It's been the standard since 2016. The Activity Index 2000 is an index from 2002. It consists of 24 items, 18 related to organs and 6 to laboratory tests. And these are the domains which it assesses, and it captures disease activity over the past 10 days, activity data. It has a bit of a drawback in that it's a binary index, meaning it only detects presence or absence, but it lacks the ability, which other indices we'll see do have. It lacks the ability to distinguish whether a clinical parameter is improving or worsening compared to previous assessments, or even if it's a new symptom. It's quite short on the one hand, and it's the SLEDAI-2K, which is an evolution, an update of the previous SLEDAI that existed. And in fact, with the SLEDAI-2K, what it adds is the persistent activity of proteinuria, rash, alopecia, and mucocutaneous involvement. This is the table itself. The ones that score the highest are usually neurological, vasculitic parameters, and so on. And those with the lowest scores are lab parameters or constitutional symptoms like fever. As such, it can have a maximum of up to 105 points, but we hope no one ever reaches that score. And like many others we'll see, it's a scale where the score determines whether the disease activity is low, moderate, or high. In this case, up to 3 points on the SLEDAI-2K is considered low activity, up to 6 is moderate, and beyond that, high. However, there are certain conditions that may allow a patient to still be considered as having low activity, even if they don't actually have 3 or fewer points on the SLEDAI, which would be 4 points or less. As long as there is no major organ involvement, no new clinical symptoms compared to previous evaluations, our global assessment is 1 or less, the prednisone dose is below 7.5, or the patient is on maintenance doses of immunosuppressants or biologics and remains stable without new clinical manifestations. The SLEDAI is a derivative. I'm not sure if most of you use it, but it's a computer tool, basically a calculator that is quite similar to the SLEDAI-2K and is slightly derived from it. It's also quite easy to use in day-to-day clinical practice. It's fairly recent, from 2019, and consists of 17 items. And as differences from the SLEDAI-2K, it adds gastrointestinal involvement, cardiopulmonary involvement, and hemolytic anemia. And it removes fever and urinary sediment, assessments related to urinary sediment. And it's brief. It only takes a few minutes. This would be, let's say, the screenshot of what you would see in the calculator. There are parameters that are binary, and there are parameters where you do need to include a number. And it really gives, like the DAS28, but in a lupus version, a value that falls into low, moderate, or high risk. Remission obviously would be a 0. I hadn't mentioned that before, sorry. It would also be reflected here, and then low activity would be 2.48 or less, moderate activity from that value up to 7.64, and anything above that is considered high activity. The PGA is very well known, but it's actually the simplest thing in the world. It stands for Physician Global Assessment. It's old. It dates back to 1991, and it's essentially a visual analog scale that goes from 0 to 3. Sometimes it ranges from 0 to 10, but what I've mostly seen is 0 to 3, based on the general condition of a patient as perceived by us. It reflects disease activity since the last visit, or if not available, over the past 93 days. An increase in this PGA of greater than or equal to 1 between one visit and the next suggests a possible flare-up, clearly indicating a worsening of the patient's condition. And it's a fairly simple index. It correlates with other indices and, in fact, is included within other indices that may be more complex, which can include it as an aspect to be assessed. Since it is highly dependent on the person performing it, it is recommended that, if possible, the same person always conducts it. the same evaluator, the same professional. In the past, it was used in clinical trials, sometimes even as a gold standard, but it has gradually become more standardized. In fact, the latest EULAR recommendations suggest performing it routinely at every visit. It is literally this. It's a 10 centimeter scale, hypothetically, with similar cutoff points. The assessment includes up to 0.5. From 0.5 to 1 is low activity, up to 2 is moderate, and from 2 to 3, which is the maximum, is high activity. As the last purely activity-based index, we have the BLAG, this one. I'm not going to go into much detail either. It's a bit convoluted, but I did want to mention it so that we're all aware of it. This is an index that is quite complex. It consists of 97 items filled out using a glossary. It's somewhat complicated and quite tedious, taking about half an hour to complete, and it usually ends up being limited to clinical trials. This is difficult in clinical practice. We can see that it clearly has a lot of aspects to assess, and each of its parameters, unlike the SLID-I2K, which we said was a binary index, which only detected presence or absence. This one does include and distinguish whether a symptom is present but improving compared to previous assessments, if it remains the same, if it has worsened compared to previous assessments, or if it is a new symptom. With all this and with the help of the glossary, a score is established. Based on that score and the intention to treat, several categories are established, with category A being the one with the highest, most severe level of involvement, and category E representing no involvement at all, to the point that it might not even be lupus. And the inactive state is category D. And as the last index, which is more of a mixed type, I'll mention the class I. The class I is a purely cutaneous index. We'll see it in a moment, but it gathers data on both activity and damage, and it is performed at the time of the visit based on how the patient is at the moment we are evaluating them. And I thought it was relevant to include it because the cutaneous domain seems to me to be closely related to joint symptoms. It's often one of the most common things we see. And regarding the studies and clinical trials of the biologics that are approved for lupus, if we start with belimumab, which is older, the clinical trial studies that assessed cutaneous involvement were based on what could be evaluated on the skin using the SLID-I2K or the SLID-I. But in the TULIP trials of anifrolumab, which is a more recent drug we have, when they want to assess cutaneous symptoms, they go directly to this index. Therefore, if possible, there might be a tendency that if a particular domain is to be evaluated and there is a specific index for it, then it should be used. This is the team, let's say, the left half covers aspects of activity and the right half covers aspects of damage. When filling it out, if the patient doesn't present anything, it's a 0. There's no further implication. And then, depending on which class I items they are, some are dichotomous 0-1 and others do have more grading points. But while that becomes clear as you go, the scoring is assessed on the spot and filled in accordingly. Along with all of this, a score is established with cutoff points between mild, moderate, and severe, which are the ones we have here. Now, as a true index of organ damage, the main one is the SLICE ACR-DI. SLICE, which we mentioned earlier as the group responsible, the clinical and scientific group that revised the 2012 criteria, is the Systemic Lupus International Collaborating Clinics, which in terms of indices, I believe it is the main damage index we are familiar with, which is quite old, from 1992, and consists of 42 items. And it assesses irreversible, presumably chronic damage, although in some sources I have seen it referred to as covering at least the past 6 months. These are the domains included in it. And it has clearly been observed that when there is organ involvement, it can lead to worse disease progression, a poorer prognosis, and higher mortality. And well, there are studies on this, which show a correlation, that the presence of a CEL-ICC score of 1, at least within the first 5 years after diagnosis, is associated with higher mortality. These are the questions, and if the patient doesn't have the condition, it's scored as 0, and if they do, it's scored as 1. The score is the sum of all the conditions that may be present. Since these are considered irreversible damages, the index is generally understood to reflect cumulative scores over the years. And finally, on my part, I want to mention the BIL. The BIL is similar to the SLICE ACR. It's also a damage index. Quite similar, a bit more recent, but the difference is that it's based on questions designed for the patient to answer themselves. The domains and everything are quite similar, but the questions, I think it's a bit too small to see clearly, but anyway, they're all in the form of questions. Like, has your doctor ever told you that you have any retinal involvement, etc.? So it goes like that with all the questions. It takes about 10 minutes and might be a bit quicker to assess. And on my part, to summarize, with this whole arsenal of indices, it seemed appropriate to me to include an arrow, a timeline that includes the activity indices at the top and the damage indices at the bottom. And the time range for each of them, which I sometimes find a bit complicated. How much time margin do I need to take into account to assess a patient? Since we'll all have the slides later, if any of this is of interest to you, well, there you go. And the classic one, as we've said, which is mixed, is right there in the middle. And since it's at the time of the visit, it's at the beginning of the arrow.